Good evening, everybody. Thanks, Dr. Khanna, for inviting me. Can I go ahead?
Yeah, sure.
Thanks. Okay, for any vascular surgeon who deals with issues like acute limb ischemia, people know that this is one of the most challenging, I would say it's the most challenging part uh, in their career because the criticality of the time is so important, like when cardiologists talk about golden hour in thrombolytics, PCI, and things like that. Similarly, the same thing happens here also. We are talking about a very short time duration during which, if you don't intervene, you're going to lose a limb. By definition, acute limb ischemia is sudden reduction or sudden cessation of supply of the blood vessel to the circulation to the limb. The incidence, can you put on a slideshow, please, Khanna? It's not on a slideshow. Anyway, the disease varies from place to place. Obviously, the incidence of PVD is very high in the Western world, and the incidence seems to be it will be the elderly population in our country. It is indeed a surgical emergency with high morbidity and mortality. The incidence of acute limb ischemia about 9 to 15 per 100,000 per year. There is a lower limb, and we don't see that much of upper limb acute ischemias here. The most published series report says that the incidence of limb loss is about 10 to 30%. I want you to note this and the next one, the mortality, which is 15 to 20% of this condition. These two figures over the period of years have not changed much, mainly because this only reflects the severe morbidity of the patients, what we are dealing with, or the patients always have a coexistent cardiovascular disease, cerebrovascular disease, or the COPD, things like that. So this condition is very difficult to treat. Also, the time you have is very little. So unless you intervene very quickly, you are very likely to lose a limb or the patient itself. Next slide, please. Yeah, the etiology, the reasons for acute limb ischemia commonly is embolism. Usually the source is the heart. Olden days, we used to have a rheumatic heart disease with the mitral valve disease, throwing up embolisms. It can also be due to in situ thrombosis or the peripheral arterial disease. It can be due to graft or stent thrombosis. It may be thrombosis due to trauma, or very rarely due to peripheral arterial aneurysm, such as popliteal arterial aneurysm. On the other side, you see the pie chart showing the incidence of ALI in different conditions. Next slide, please. Next slide. Over the years, we have seen the difference in the different spectrum of these etiologies. You can see that in 80s, it's predominantly embolic disease, cardiac source due to rheumatic heart disease, as I told you. But now you see currently, we see that the incidence of thrombosed bypass, that is, patients had a previous bypass grafts, thrombostent, that is, endovascular interventions has happened earlier. They're coming back with the instant restenosis. I think Dr. Henry is going to talk about it. And also primary arterial thrombosis due to either peripheral arterial disease or due to hypercoagulable state like thrombophilias. Embolization seems to have taken a backseat, not because the incidence has come down, but the incidence of other conditions have gone up. That seems to be the reason. Again, if you see that the identification of popliteal arterial aneurysm seems to be common these days, that is why this also comes in the one of the incidents of acute limb ischemias. Next slide, please. I think it's very important to understand the pathophysiology. Whenever there is a sudden cessation of circulation, there is there's a need to meet the metabolic demand of the tissues, predominantly the muscle in the lower limbs. There is a shift from aerobic to anaerobic metabolism. So there is an increase in lactate production due to depletion of ATP and leakage of extracellular calcium into muscle cells, which gradually leads on to cell death. The severity of the acute limb ischemia depends on the degree of obstruction, where the site of occlusion is proximal or distal, and the presence of earlier PVD, so that the presence of collaterals, say for example, patient had a previous PVD, is very likely to have some amount of collaterals, which keeps the leg going. Also, it depends on the type of tissue affected. The systemic perfusion, such as the cardiac output and peripheral vascular resistance, also determines the end result or the outcome of the either limb salvage or the patient salvage. Next slide, please. In the limb, for example, the first one to be affected will be nerve. So the patient presents with severe pain. So the cell changes starts happening within 20 minutes. Even though outwardly it starts manifesting later, the first symptom, pain, is due to the ischemic neuritis. And the muscles will be the last one to get affected. That is 6 to 10 hours. By the time the skin changes happens, I think probably you can take it for granted that the whole tissue, that is the muscle, nerves, everything is gone. So probably it becomes non-salvageable. So if you see any kind of skin change, like a mottling or skin darkening or black skin, that is a typical gangrene, I think it's probably too late for revascularization. Next slide, please. How to differentiate between embolic disease and the thrombotic episodes? Quickly, I can tell you the onset of embolism is very, very classical. It just happens, within a stroke of a second. Very, very sudden onset. Thrombosis, it happens a little bit over a period of time. And also embolus, it can be like multiple sites, like you can have a CFA, you can have a popliteal occlusion. On thrombosis, usually it's a long segment disease. And the embolic source usually can be noticed. For example, somebody with a known rheumatic heart disease with AF presenting with acute limb ischemia, you assume it's a cardioembolic disease. If there is no history, you probably think in terms of acute thrombosis or peripheral vascular disease. And contralateral pulses is usually present in embolic episode, not present in PVD because usually it's a diffuse disease. Claudication is absent in patients with embolic episode because patient does not have any previous disease, and usually is present in patients with PVD with acute thrombosis. Next slide, please. The grading of acute limb ischemia is very important because the intervention depends on how the patient presents. You see the grade 1, grade 2A, grade 2B, grade for classification, and it's clearly show the grade 3 is patients and permanent nerve damage happen. So these are the patients who is very unlikely to benefit from any intervention. So we are going to deal with patients with 1, 2A, and 2B, and what are the options available? Next slide, please. Okay, it is not my saying. You see that way back in 1830s, in late 19th century, George Ross, surgeon, said that any fool can cut off a leg. Takes a surgeon to save it because it is very, very difficult to save the limb in acute limb ischemia, and that's what surgeons are fighting for it. It's really indeed a hard job. When you're trying to save a patient presenting with an acute limb ischemia. Next slide, please. Okay, what is the main target? Our aim is to give a rapid restoration of arterial flow. Unless you give the blood flow very quickly, even though it's not immediate, very quickly to the diseased limb, you're not going to bring back the survival. For viable limb category 1 ALI, revascularization should be performed on an urgent basis. That is within 6 to 24 hours. That is, you have time factor. That is 6 to 24 hours. For marginally or immediately threatened limb, that is category 2A and 2B, the revascularization has to be immediate. That is less than 6 hours. And that's all the time you have for assessment, investigation, and treatment, and bring back the circulation quickly. For non-salvageable limb, like category 3, I think amputation is better performed rather than trying to salvage, because if you try to reperfuse the dead limb, you're very likely to create a lot of reperfusion injury, creating high mortality. Next slide, please. Next slide. Investigations. Commonly, all that you need is a confirmation of diagnosis. I think a good history, clinical examination, and pocket Doppler assessment will throw away a diagnosis. If in doubt, you can do a duplex scan, if available, immediately on site. Next slide, please. I think just keep clicking, Dr. Khanna. Yeah. DSA, I wouldn't advise because it's invasive, it's time consuming. Next slide. We usually go for, can you click on? Yeah. We usually go for CT angio because it's very quick. It's available on site, and then you can look at the picture and you can see where the site of occlusion is, the extent of occlusion is, and you can decide on the treatment straight away. Next slide, please. This is a picture of CT angio which shows complete cutoff of the left common iliac and no distal flow. And you have to immediately reperfuse. Otherwise, you can imagine the amount of tissue destruction because there is no common iliac, no internal iliac, and no leg perfusion. So you are looking at a large amount of muscle ischemia, including buttock, thigh, and calf muscle. These patients are very likely to have a massive reperfusion injury when you are trying to do some intervention. Next slide, please. What are the options we have? We have revascularization strategy, can be catheter-directed thrombolysis. It can be surgery like surgical thromboembolectomy. The technique will provide most rapid restoration of the arterial flow. It should be decided immediately. Prolonged duration of ischemia, that is more than 6 to 8 hours, is common factor in patients requiring amputation. That is, if presents late, more than 8 hours or 8 to 12 hours or 24 hours, I think amputation may be better. Next slide, please. Yeah. I think those who are dealing with reperfusion, I think revascularization should be very careful in knowing the physiology of reperfusion syndrome. It causes hypertension, hyperkalemia, myoglobinuria leading on to renal failure, and you should be prepared to deal with all these complications. This also leads to compartment syndrome. You should be able to identify and treat immediately. Patient can land up in ischemic neuropathy, muscle necrosis, recurrent thrombosis, which should be able to prevent, and also edema, which again can lead on to compartment syndrome. Next slide, please. What are the interventions options available? We have both endovascular and open. These days, I think majority of the patients go for endovascular because many studies like Rochester study, Style, Topaz phase 1, phase 2, have gone on to say that thrombolytics, endovascular therapy is better than surgical intervention, except in very small group of patients who has definitive embolic episodes. Endovascular therapies can be thrombolytics or mechanical thrombectomy, and surgical interventions can be embolectomies, can be bypass surgery, can be a hybrid like intraoperative thrombolysis combined with embolectomies, and of course, for late presentation, amputation. Next slide, please. Right, what is catheter-directed thrombolysis? It is direct delivery of a thrombolytic agent into the area of occlusion. It prevents systemic bleeding complication. It lyses the clot in both large and small vessels. And if you can see the offending lesion, when you come out, you can treat it immediately. What are the disadvantages of catheter-directed thrombolysis? Usually, it's a slow process. You need some time. If your patient's presenting delayed, I don't think you have time, like 12 to 24 hours for the reperfusion to take place. Still, there is, even though it's not a systemic thrombolysis, still there is an element of risk with the systemic bleeding like ICH and retroperitoneal bleeding. Next slide, please. Next slide. Right, what are the absolute contraindications? Patients with active bleeding disorder, GA bleed, cerebrovascular event within 6 months, intracranial spinal surgery, head injuries. And there are loads of relative contraindications. In fact, these days, with our availability of thrombolytic agents, we can get over all these contraindications, and we are using it for lots of patients with thrombolytic agents. Next slide, please. Right, you can do ipsilateral puncture or a contralateral puncture. I, by and large, use a contralateral puncture for 2 reasons. One, you can deal with the proximal lesions. Also, when you come out, you come out to the contralateral side, so you can use a closure device and come out so that the incidence of bleeding complication is extremely low. Next slide, please. There are also percutaneous mechanical thrombectomies available. I will show you in a minute about what are the devices available shortly. It disrupts the thrombus so that the dosage of thrombolytic agent is reduced. It can also be used in patients who are contraindicated to have thrombolytics. What are the disadvantages? It can be used only in a large vessel, and there is an amount of money involved in this because these devices do cost a lot of money, especially in India, where the money plays a big role. Next slide, please. Yes, this is one of the common commonest device we use. It's an angiojet device, which can be used for both the pharmacological as well as mechanical thrombectomy. It involves what's called a Bernoulli's principle with a hydrojet mechanism, where there is water comes out in a high force, and due to Venturi effect, sucks out the clot. You can use pulse spray, that is usage of thrombolytic agent earlier on, 20 to 30 minutes, so that your effect of thrombectomy is very, very quick. And this is one of the commonest devices we use. It can also be used for venous thrombectomies. So it comes in 8 French, 6 French, 4 French devices. 8 French is for venous, 6 and 4 for arterial thrombectomy device. Next slide, please. This is the previous one. This is previous one, please. The next one we have is what's called a penumbra device. Next, previous. Penumbra, usually what's called an Indigo system, which is purely a suction system, which is primarily used in the neurointerventions, and we use it for the limbs also. The advantage of doing this endovascular procedure is at the end of a thrombolytic or at the end of thrombectomies, if you clear the vessel and if you see an offending lesion like a stenosis, you can put in a stent, and then you are treated the patient once for all, so the patient need not come back for another procedure. So these are the advantages of endovascular procedure. Next slide, please. Right, advantages of the endovascular are minimally invasive, preserve the morphology, thrombus can be removed even as small as like a foot and ankle lesions. It converts emergency to elective procedure, and of course the reduction in the magnitude of surgical procedure. Next slide, please. Of course, as I said earlier, there are a lot of complications if you're using a thrombolytic, especially in a high dose, like predominantly it's intracranial bleeding or retroperitoneal bleeding. Next slide, please. Right, embolectomy is the commonest surgical procedure we do. We use a foreguarding catheter of different ranges, of different sizes, and usually it's very good on embolic cases because it's a very quick procedure, can be done under local, especially patients got a high morbidity. Next slide, next slide, please. Bypass is usually reserved as a last resort. You have failed in your endovascular, you failed in your embolectomy, and then you do an on-table angiogram to see a lesion, then you go on to do a bypass procedure. So I think these patients are the ones who have a high technical failure, high mortality and morbidities. Next slide, please. Right, I think you should understand the reperfusion injury. As I said earlier, it causes severe muscle edema and muscle injury, and which can go on to renal failure, cardiac dysarrhythmias, multi-organ failure, DAC, etc. And you should be prepared to meet with the help of either a critical care specialist or anesthesiologist on the table. Otherwise, do not have time to manage hyperkalemia when you're treating the patient yourself. Next slide, please. Fasciotomy is usually combined. If you're expecting either prophylactically or on-table therapeutically, when you're expecting a reperfusion injury. The compartments in the leg are 4. You have anterior compartment, you have a lateral compartment. In the posterior, you have what's called superficial and deep. By and large, we do a liberal fasciotomies to prevent compartment syndrome, because even though you've done a successful revascularization, patient can lose a limb if you have not released the compartments, especially in delayed perfusion. Next slide, please. Right, ladies and gentlemen, this is a small algorithm. I have put it across to you. If you are coming across any patient with acute limb ischemia, immediately give a bolus of heparin, which prevents propagation of clot. And then depending on the type of presentation, type of lesion, you can subject the patient to either endovascular or surgical. And the take-home message will be, ladies and gentlemen, acute limb ischemia is a very serious condition whose risks include loss of limb and with high mortality. Most acute limb ischemia these days are caused by atherosclerotic disease, and classification of acute limb ischemias into various levels offers several clinical benefits. The most important variable you should understand in producing a good outcome are early diagnosis. I think that is what I want to drive home this message, because if people miss a diagnosis, I think whatever you do, I think you're going to lose whatever. You can have a fantastic technologies in your place, but I think if you don't make an early diagnosis, I think you lost the limb and you may likely to lose the patient also. Thank you. Thanks, Dr. Khanna.
Thank you very much, Dr. Balaji. That's great as usual. Now, let me invite Dr. Tulio Navarro who is working there. Dr. Navarro. So he's going to be speaking on stem cell therapy. And then after that, we'll be talking about the critical illness. Welcome, Dr. Navarro. So how is the situation in Brazil for COVID? We are, we won't, I think we'll probably beat Brazil or United States very soon.
Yes, thank you. Can you hear me, Dr. Khanna?
Yeah, very well. We can hear you very well. And welcome
Thank
to
you,
India.
Dr. Yeah,